Greeting ladies and gentlemen, my name is Warit Rungsrithananon from Bhumibol Adulyadej Hospital, Royal Thai Air Force, Thailand. It is an absolute privilege and honor to represent my colleagues for abstract presentation here at SAGES 2020. Our study title is Impact of Continuous Rectus Sheath Block on Postoperative Pain and Early Outcomes After Laparoscopic Bariatric Surgery. I have nothing to disclose. Morbid obesity is one of the leading global health crises with increasing prevalence. Apart from medication and addressing lifestyle, laparoscopic bariatric surgery is also an effective way to achieve weight loss and has become increasingly popular choice of management over the past decades. Despite benefits of various types of bariatric surgery, they also pose risk for serious complications. Postoperative pain control in obese patients can be very challenging due to complexity of the disease. Overtreatment may cause respiratory depression, while inadequate pain control may delay the recovery. This is where multimodal analgesia comes into play. The goal is to maximize analgesic efficacy while reducing adverse drug events. Effective pain control can reduce opioid consumption, enhance recovery, decrease overall morbidity, medical costs, and time away from work. Rectus sheath block is one of the modalities used for pain control in abdominal surgery. It can be given as a single injection as well as continuous infusion. Also, it can be administered externally or even from laparoscopically. Our aims were to determine the effect of continuous rectus sheath block on postoperative pain as well as assess its effect on other early outcomes following laparoscopic bariatric surgery. We conducted a retrospective cohort study by reviewing medical charts of all morbidly obese patients who underwent laparoscopic bariatric surgery from January 2014 to June 2019 at Bhumibol Adulyadej Hospital, Bangkok, Thailand. Eligible criteria include morbidly obese patients who is over 18 years of age, first bariatric procedure without prior abdominal surgery, no intraoperative conversion, complete documentation and complete infusion time, and no referral or withdrawal after the treatment. So we started with a total of 103 patients of morbidly obese patients who underwent laparoscopic bariatric surgery over the 5 years period, and after 20 were excluded, 83 eligible records were divided into a non-RSB and an RSB groups. All patients were operated by the same surgeon, so a single surgeon with a standardized general anesthesia. Conventional 5-port technique was performed on all laparoscopic sleeve gastrectomy. This is a short video showing RSB catheter insertion using BAH technique. First, place the tip of the needle at the posterolateral border of the rectus muscle just above the posterior sheath, and then a nerve block catheter is inserted through the guided needle. Once the catheter is inserted through, the needle is removed, and after securing the catheter to the skin with the suture, anesthetic solution is infiltrated and can then be observed in the wound. Proper placement of the catheter is finally confirmed by palpation from within the abdomen. The RSB catheter insertion was performed by a surgeon before the wound closure, and the catheter is connected to an elastomeric infusion pump containing 0.15% bupivacaine and continuously infused at a fixed flow rate of 5 ml per hour, and after 48-hour post-operative, the catheter is removed. Patient characteristics were obtained, including age, sex, height, weight, BMI, ASA classification, operative procedure and duration, intraoperative blood loss. Primary outcomes was postoperative pain using numeric rating scale of 0 to 10 at varying times. Average pain score at the first 24 hours and the first 48 hours were calculated. Secondary outcomes included number of rescue analgesia, postoperative nausea and vomiting, time to ambulation, length of hospital stay, surgical site complication including hematoma and infection. Comparison were made between two groups. Statistical analysis was done using SPSS software. Normally distributed variables are reported in means. For results, baseline patient characteristics were compared. No significant difference in age, weight, height, BMI, SA classification was found between groups. Majority of operations were laparoscopic sleeve gastrectomy, accounting for more than 95% in either groups. Operative time and blood loss were not different. For post-operative pain, mean pain score in the RSP groups are significantly lower at the 2nd, 4th, 8th, 12th, 24th hour despite no significant difference at the 48th hour. Average pain score at the first 24 hours and 48 hours were also lower in the RSP group. For secondary outcomes, RSP group has significantly fewer dose of rescue analgesia, faster time to ambulation, and shorter length of stay. Post-operative nausea and vomiting and incidence wound complication were not different between groups. And actually, no wound complication were found in both groups. Repeated measures plot indicates lower pain score in the RSP group from the early post-operative pain period throughout the first 48 hours. From our study, we observed that continuous rectus sheath block following laparoscopic bariatric surgery were associated with lower pain scores at varying times in the first 2 days, as well as fewer doses of rescue analgesia, fast time to ambulation, and shorter length of stay. No surgical site complications were caused by the intervention, and insertion could be done within minutes without significantly delaying operative time. Limitation includes the retrospective nature of the study. No imaging confirmed of the catheter aid placement, no placebo controlled. Further prospective study and randomized control trials are essential to determine the effectiveness and efficacy of the RSP, and comparison to other modalities should be done as well. In conclusion, continuous rectus sheath block is potentially useful modality for post-operative pain management following laparoscopic bariatric surgery and could potentially improve overall patient outcomes. Thank you very much.